all. Thank you, AIOC and sir, for giving me this opportunity to present in front of you. So, I'm going to the basic. I'm going to talk about pupil evaluation. Why it is important? Because pupillary function is the most important clinical sign in patients with vision loss and neurological disease. There can be afferent pupillary defect, which can point towards any lesion in retina, optic nerve, chiasma, or tract, or there can be efferent pupillary defect, which can point towards a serious neurological condition such as aneurysm or tumor. So this is a normal pupil. A normal pupil is a single aperture present in the center of the iris, slightly nasal. It controls the retinal illumination, it reduces the optical aberration, and it also helps in depth of focus during accommodation. Before examination of the pupil, the prerequisites are room illumination, permits easy control to the background illumination, source of light. As you know, indirect ophthalmoscope is the best source of light to elicit RAPD or pupil reactions, pupillary gauge to measure the size, slit lamp, neutral density filters, and in special situations, some pharmacological drugs. Also, we need a little time of the clinician and sound understanding of pupillary functions. Pupil evaluation can be done by number, location, size, shape, color, reflexes, and pharmacology. So, pupil can be tested by direct light reflex, consensual reflex, swinging flashlight test, and near reflex. Pupillary disorders mainly classified into three types like abnormally shaped pupil, abnormal pupillary reaction, and unequal pupil size. So coming to the size and shape, so that is there can be a polychoria which can be true with an extra sphincter and can be pseudo. The size can be congenital, there can be congenital meiosis or congenital mydriasis. Basically, the size of the pupil is influenced by ambient light, state of the retinal adaptation, level of arousal, and patient's age. Small pupil points towards pontine hemorrhages, narcotic intoxication, pilocarpine, whereas large parasympathetic blockage uses use of stimulants or state of high anxiety. Shape, there can be congenital aniridia, that is PAX6 gene involvement, also associated with WAGR syndrome. Shape can be abnormal in iris coloboma, correctopia, ectopia lentis et pupillae. Abnormal can be because of sphincter tear or iridodialysis in blunt trauma, or there can be posterior synechia. We check the reactions, and most commonly, what we do is swinging flashlight test to detect afferent pupillary defect. So here the pearls are the patient should look at the distant target. Here I am testing in a children, which is a little difficult. Uh, RAPD can be measured with a neutral density filter. You have to perform swinging light test in both eyes till it is equal. Abnormal reaction can be seen in cluster headache, migraine, astrocytoma, Horner syndrome, and after carotid puncture, and during or after seizure activity. Coming to abnormal shape, size of the pupil, we call anisocoria. That is difference in two pupil by 2 millimeters, which is common and normal in 10 to 25% of the population. Here, the key is you should always check a dilatation lag. So, in Horner syndrome, there are weak dilator muscles and we get a dilatation lag. So, if there is dilatation lag, we don't need anything else to diagnose Horner's pupil. So, here is one case of 8-month-old baby came to my OPD with a mild ptosis in the left eye. LPS action was good. On keen observation, there was an isocoria. There was difference of 2 millimeters in both the pupils. There was dilatation lag. Pupil was reacting to light, and on history, there was decreased sweating on left side of the face. So the differentials were third nerve palsy, ocular myasthenia, mechanical ptosis, or sympathetic palsy, that is Horner's syndrome. So what we did was MRI chest and head neck, and we got an Pankos tumor, that is a mass on the apical portion of the left side of the lung. So typical features of Horner's are mild ptosis, upside down ptosis, meiosis, anisocoria, dilatation lag, which is most common. Everyone should not go for tests, pharmacological test, but look for dilatation lag. Apparent inophthalmos, accommodation can be paresis or increased amplitude both. Hemifacial anhidrosis, And you can see heterochromia iridis, most commonly seen, and ipsilateral straightening of the hair. It can be a central horner, pre and post ganglionic. Now we need pharmacological testing to differentiate between the two by hydroxyamphetamine tests. Cocaine is not available, so we usually don't perform it. So this is a chart how we differentiate between pre and post ganglionic testing of Horner syndrome. Apraclonidine is also used. This is also not available in India so commonly, but this can also, if you put in a Horner size, that is small pupillae, there is a denervation supersensitivity of the alpha receptors, and we get a reverse Horners. So this is a busy chart, but everyone should know that anisocoria should be tested in a dark room and a bright room. If anisocoria is greater in dark, do apraclonidine test. If positive, it is Horner's. If not, it is usually physiological. If anisocoria in more in bright light, then more common is third nerve palsy uh, with abnormal muscles. If the muscle movements are normal, then think about other things like AD's pupil or angle closure glaucoma, where there is a vertically oval fixed mid dilated pupil. So Horner's being sympathetic palsy. Now coming to parasympathetic palsies, we have AD's, third nerve, and pharmacological pupil. In AD's, we get vermiform movements of the eyes. Okay, there is a lesion at the ciliary ganglion, uh, and there is aberrant regeneration of the fibers originally destined to ciliary body, now innervating the sphincter. So there is abnormal reaction. You can check on the slit lamp for the vermiform movements at the pupillary margin. Most commonly, what we observe is accommodative paresis. Patient complains of difficulty in reading. If it is also associated with deep tendon, absence of deep tendon reflexes, it is called home Eddy's pupil. Third nerve palsy, everyone knows if it is involving pupillary fibers, that there is anisocoria, then we should always think about something serious, that is aneurysm, tumor, or uncal herniation. Wernicke's hemianotic pupil is mainly seen in lesions in the optic tract, that when we shine a light, when the light reflex is absent, when light is thrown on non-seeing part of the retina, but reacts when the light falls on the seeing part of the retina. There is another condition called light near dissociation. I'll cover just two. That is Perinaud syndrome, already covered by Sir. That is dorsal midriff syndrome. Most commonly, there is accommodation reserved and light reflex is gone. The causes can be pineal gland tumor, hydrocephalus, and midbrain hemorrhages. There is defective light reaction of the pupil, near reflex is preserved, vertical gaze abnormality, downbeating nystagmus, bilateral superior oblique palsies. The I'll skip the video for now. And the last is the Argyll Robertson pupil. The difference between the two is in Argyll Robertson, the pupils are always small. You get a small pupil, very rarely seen in common practice because the reason is syphilis, which is now rarely seen. But we need to check for near reflex also whenever we are evaluating pupils. So my take home message is testing the pupil's reaction to photic and accommodative stimuli is a key part of any ophthalmic examination. Relevant history taking and keen observation for subtle clinical signs can detect life threatening conditions. Thank you.